are going to start. Tonight's content is pretty long because we go into lots of detail, particularly about things like etiology and epidemiology and all sorts of stuff about schizophrenia. And so we're not going to do the case studies today. We're going to review the exam instead. So about that, your exam results, let me move this over here. Fell on a normal curve with a slight skew, as you can see. And I'm not sharing screen on Zoom. I need to do that. There were 7 questions. There were only 2 questions that over half the class missed. And so I tried to be a little more generous and added an additional standard deviation and took it down to 13 rather than the obligatory 16 and a half or 17 and a half students or whatever it was. And went with 13 or more. And there were 7 questions that 13 or more people missed. And so after tonight, you will see an additional 7 points added to whatever your raw score was. In terms of raw scores, here is the info on those. You all have access to the correct answers now, yes? Okay, and so if you are interested, feel free to take a look at those. But again, if more than half the class missed it, I consider it to be a bad question.
Sorry, Liz, you said you were going to be sharing your screen.
Yes.
Okay.
It says that it's sharing, and yet it's not.
Thank you. It's sharing.
It's working now? Okay, good. Yeah, a lot of the, yeah.
I know. I was like, I've never heard of that. Baby technical. Like postpartum.
It's a thing that people used to refer to as postpartum depression, 100 years ago.
Yeah.
And so, there's actually a debate right now over whether or not, because the Barlow text is considered sort of the most common text that's used for this sort of course. And there's even sort of this discourse right now over whether or not we should even be calling things like a DSM diagnosis abnormal psychology or psychopathology and all these sorts of things, as opposed to normative human experiences. And that debate has kind of risen again with the release of the DSM-5 TR and things like prolonged grief syndrome, for instance, which some are arguing is pathologizing the normal human experience of grief, but others are saying, no, if we use it more as a category of this thing that people want help with, we're not saying it's a disease, we're not saying it's a disorder. And if that's the case, why are we putting it in the statistical manual of mental disorders? And so just the language around that and what those different things mean, right? We talked about that a lot with personality disorders. We're gonna talk about that a little bit today too, when we talk about psychosis and schizophrenia and all of those things. So overall, the exam scores were pretty good. I know you all were super nervous and you all did pretty well. So, yeah. Any questions about those numbers? Cool. Somebody emailed me and asked me about curving. I am not going to do a curve because if I, oopsies, wrong thing. Get out of here, clients. Because if I did a curve and I were to go back to that histogram and I were to take that and force it into a curve, this would be down here and you would all get lower grades because that's how curving works. So yeah, we'll not be forcing your scores into a normal curve because that doesn't bode well for anyone, and an average of a C is not really a useful paradigm in a program that requires a person, have at least a C to pass. So yes, there will be the additional 7. And to be fair, I think the person who asked that just didn't understand what they were asking. So yeah, there will be an additional 7 points added to everyone's score for those 7 questions, regardless of, even if you got them right, I'm going to add the additional points just to keep things consistent and fair for everyone. And I was told that I'm allowed to do that. So that is that for those. All right, I'll start with some definitions here because these are terms that we're going to be using kind of throughout today. So when we hear about negative and positive symptoms, negative is the absence of an experience that would normally be there. So a person that has a negative affect, it is a lack of emotional expression. We want to differentiate things like this from, say, an experience of emotion, because the person might still experience all sorts of emotions, but demonstrate a flat affect in the eyes, the face, so on and so forth. Most of you have probably seen what that looks like or know people who have that sort of facial expression. Let's see, abolition, inability to initiate and persist in activities. This is different than amotivation. Abolition, pick apart the word for me. What do you think this means? Look at the VOL part. Vol what? So similar words being things like velocity or volatile and so on and so forth. And so this is not so much the same thing as we see with depression, where there's amotivation. This is the person has a very literal inability to initiate certain activities, even things that they do have motivation to do. Alogia is absence of speech. Anhedonia, we've already said that before. They define it as a presumed lack of pleasure. And one could also counter that and say that you can simply ask your client if they, a lot of the discourse and the research around things like schizophrenia, particularly when folks are struggling with things like a thought disorder and they're not able to communicate, or let's say they're catatonic. And so there's this presumed anhedonia, whereas the person with depression, you can ask them and they might tell you they no longer enjoy the things they used to, that sort of thing. Asociality, lack of interest in social interactions, and affective flattening. Or sometimes we even say a blunted affect if it's not totally flunt, but just sort of getting there. Flunt, did I say flunt? You know what I meant, flat. Flunt is a new word that means between blunt and flat. I made it up. Go me. That's a neologism, which I think is going to be on the next slide, maybe third slide. Look at that. We're so meta. Positive symptoms. Things that happen that don't normally happen. And these are kind of contentious. There are very, very clear hallucinations, like a voice that no one else hears, or a thing that you see that no one else sees. And there are also gray areas. A lot of people that experience hallucinations will describe seeing things that are there, but not the same way. So the table is floating. The patterns in the floor become more prevalent. They looked at the tree and suddenly it had eyes, or the branches moved in a way that they don't typically move, all of those sorts of things. I've had patients say, hey, Liz, I was scared of you one day because your eyes turned red and I thought you were a demon. I'm like, that's fine. You're probably not the first, but it wasn't a creation of something new. It was a misperception of something that existed. In this case, my eyeballs. Fine. Hallucinations can be any sense. It is not common for people to experience hallucinations of all five senses at the same time. If they do, it's probably more likely a flashback or some other kind of experience. Majority of folks that are experiencing psychosis, the hallucinations are either auditory or visual, sometimes both, but rarely. That's one of the reasons why when we're working with somebody that has hallucinations, we'll encourage them to try to engage with the hallucination with some other sensory modality. Did you talk to the face? What did it say? What was the gender? What did it look like? What color were its eyes? What did the voice sound like? Did the voice sound like, was it a masculine or feminine voice? Did it sound like someone you know? Could you touch it, Because as soon as they are able to then activate those other sensory parts of the brain, often the hallucination will sort of fade, right? Because if you see a face, you try to talk to it and hear it, or you're engaging those other sensory pieces, it goes away. If you try to smell it or touch it, it goes away. Delusions, also kind of a gray area. So fixed false beliefs that are persistent despite conflicting evidence is one definition. That is the definition of the DSM. The definition in your book is gross misrepresentations of reality. And as with all things, these are culturally bound, right? So if you have a delusion that horse dewormer will cure COVID, will we call that a delusion? Maybe, maybe not. I mean, well, and what's that?
I'm thinking about like police experiences too.
And again, lots of culturally bound pieces here. So the big thing here is that the beliefs are persistent despite evidence. And that's one of the big things we do in cognitive behavioral therapy for psychosis is we try to engage in this sort of Socratic method of presenting counter evidence and see how the person is able to integrate that into their delusional framework. If it is truly a delusion, they will integrate the information. It will become part of the delusion. They will have an explanation as to why that sort of confounding information exists. If they are either responding well to treatment or it's not quite a fixed delusion, it's sort of still developing or amenable to treatment, they will be able to consider that other evidence. Oftentimes delusions are about things that it is impossible to have evidence for or not have evidence for. We'll talk about different types of delusions here in a minute. Thought disorder, disorganized thinking. So when you do a mental status exam and it asks, you see a person presented as disorganized. That can mean a lot of different things. Disorganized appearance, shirts on backwards, everything's kind of all over the place, socks around the hands, whatever. Things are disorganized in that way. But thought disorder, formal thought disorder, is referring to any of these things. So perseveration, everyone knows what it sounds like to have a conversation with someone who is perseverating. Blocking. And again, these are things that are very subjective. So you can observe them based on the person's speech patterns, but you also want to ask them. A person can usually tell you, I had this strain of thought and it just stopped, right? These are all things that everyone experiences, by the way, not just folks with psychosis. Thought insertion. So this is a very literal belief in which the person experiences their thoughts as coming from an external thing. And often they will develop some sort of delusional framework around that. So I'm having these thoughts that aren't mine. It must be a chip in my head. I'm having these thoughts that aren't mine. It must be this other, some sort of alternate explanation that they have for it. Circumstantiality. This is when the person will essentially tell stories instead of giving a more concrete answer. This is also something that's culturally bound because there are a lot of languages in which this is just the normal way of communicating. And that, to English speakers, it seems superfluous. And because it's culturally bound, if you're working with someone who's a native English speaker, you will definitely notice it. For instance, I have a client who, I don't even know where to start because he's so circumstantial. This morning, we were doing just a quick, ACEs kind of thing. And I asked a very simple sort of yes or no question. And the question was, did your parents allow you to have a lock on your door? And didn't answer the question, but started talking quite a bit about the house that he grew up in and the shape of the doors and the decor of the house and the colors and all of these other things that were related somewhat, but didn't actually answer the question. So kind of all across, I'm like, okay, hold on, let's go back to that question. Had no, concept that he was even doing that. That's different than loose associations. Loose associations is when the person says, yes, the door, oh, the window. And then they fell out the window and there was, and they kind of go from one thought to another, this sort of stream of consciousness, but it's not linear. It's sort of jumping around. And if you sit and really listen and map out a person's loose associations, you will see that they're not as loose as we might think. There's usually some sort of metaphorical link between the things they're saying, right? So the difference is with circumstantiality, I say, what color is the sky? And the person starts to explain like the light spectrum to me instead of answering the question. Loose association is I say, what color is the sky? And the person says 7 or truck or something completely seemingly unrelated. But for them, there's this very quick jump from what I asked to the word blue to whatever this next concept is. And you can try to kind of map those things out and figure out where that metaphor is. What are they really trying to communicate there?
You ever just ask them?
Oh, yeah.
Okay.
Absolutely. A lot of CBTP is around helping the person understand and get to kind of the heart of the meaning, because it's very frustrating for someone who's experiencing that too. They know that they're not being understood. They know that they're not communicating clearly. Disorganized speech. So this is what we often use to observe things like thought disorder. So echolalia is, you've probably heard people do this. You see this a lot with children that are learning how to talk. They will just repeat back, parrot back what you say. It can also be a person who repeats just specific phonemes. It might sound like a stutter or a tick almost, where they are just completely repeating repeatedly repeating the word or the sound over and over. They sort of get stuck on it. Incoherence. Word salad. This is one of those terms that gets used a lot in media, and you all already know how I feel about that, typically incorrectly. So word salad is not when people are saying things that we disagree with or that sound silly or that are hyperbole or that don't make sense. Word salad is when I look at the table and I say truck, blue, 7, legs, wood, it's not really a sentence, or it's a sentence, but it doesn't quite make sense. The wood trucked 7 table up the legs. What does that mean? Those words aren't actually, verbs or nouns or etc. incorrectly. So like that sentence, bunch of words, you knew what I meant, but it didn't actually follow a sentence structure. That's what we mean when we talk about word salad. Anybody know the technical term? Which I should have put up here and just realized I didn't. So it would be schizophasia. Yep, that's a PDF, so I can't edit that. Phagia referring to anything that is speech related, and schizo comes from schizophrenia. Pressured speech, same thing. So oftentimes people that are experiencing word salad will also exhibit pressured speech, where it's coming out so quickly that they're not able to form a linear sentence. Pressured speech is also something we see a lot with folks that are manic. We saw that in the video of the gentleman that was experiencing a manic episode, where he's speaking very, very quickly and it feels like the words just cannot come out quickly enough. Very difficult to interrupt. The person might not be speaking in a way that is meant to be reciprocal. They're just, kind of word vomiting, for lack of a better term. Word approximation, so abnormal and incorrect use of words in the middle of sentences. You will see folks, a lot of this is when the person doesn't have the word for something, or they experience this sort of thought blocking where the word goes away, and so they'll substitute another word that's similar but not quite. So they want to say road, but they say truck instead because trucks are related to road. But they'll do this kind of repeatedly throughout the sentence, and that's really where it's important to really help the person slow down and find another way to communicate. Maybe it's drawing, pointing, or simply asking different ways of asking the question to kind of help them move through that metaphorical type of speech. And then neologism is a new word or expression. One of my favorite clients is actually gonna have him attend this evening, but he was unable to because he's currently incarcerated. But very, very insightful into his schizoaffective diagnosis and his speech pattern. And he will tell you, he'll go on these very sort of superfluous rants about the universe and all these things, and he'll make up words, but then he'll tell you, my brain created this word because I didn't have a word for it. And he'll mash words up, he'll put words together. And if you sit and map out what he's saying and really listen, you can figure out sort of metaphorically what he's saying. And oftentimes he speaks in metaphor, and it doesn't have this sort of linear, concrete, symbolism with which we normally think of when we use language. And sometimes the words are these, you'll hear a lot of like clanging, where the person will put together words that sound similar. This person will also put together words. He'll say things like my schizoaffective, schizophagia, schizophrenia, he'll keep adding words to it, but he'll say it in this rhythmic sort of way, where it's purely based just off the sound of the words. So lots of different things there. And yeah, delusions. So these diagnoses, I'm going to tell you right now, please do not raise your hand and ask me the difference between this one versus a different psychotic disorder diagnosis, because I posted a really handy dandy chart for you on Canvas, and I will tell you to go look at that. Also because I don't have them memorized, so that's a cop out. Full disclosure. So delusional disorder, presence of at least one delusion with a duration of at least 1 month. Criterion A for schizophrenia has never been met. Obviously, this is a very circular type of lecture, because despite delusional disorder being listed first in the DSM before schizophrenia, they reference criterion of A of schizophrenia. So we're going to be circumstantial here for a minute and talk about criterion A for schizophrenia, which is positive symptoms. Additionally, the person can have positive symptoms because we like to keep things nice and simple, right? So they're not prominent and they are always going to be related to the delusional theme. In other words, if they're having hallucination, it is a manifestation of the delusion and the delusion remains prominent. For example, fellow I worked with at the state hospital has a belief that he is engaged to be married to a very famous person. And he will hallucinate things like her looking directly at him when she's on TV or speaking to him or saying things that she didn't actually say, but it'll be similar to what she said. So it's what might be referred to as a gross misrepresentation. She'll say one thing, he'll hear a few different words, and then he'll be like, she just mentioned me. And I'm like, oh, did she though? Let's rewind and see what she actually said, right? Lots of stuff there. The person doesn't show marked impairment in functioning apart from the impact of the delusion. So what does that mean? This person is at the state hospital because he thought it would be a good idea to go to the airport to pick this woman up when she arrived in town, much to the chagrin of her bodyguards, so on and so forth. Would we consider that to be a big impact on function apart from the delusion or its ramifications, or would we consider that to be a direct result of the delusion? Things get sticky there. Because for delusional disorder, the beliefs often become such a huge part of the person's identity that it's very difficult for them to not have some sort of functioning impact, because the delusion is, you see it manifested throughout their life, right? It often becomes very obsessive, things like that. And not all the time. You might have lesser versions, right? I'm talking at the inpatient level, but you might have lesser versions where the beliefs might be useful for them in some way, and so it helps their functioning, right? Socioculturally bound. If they have manic or major depressive episodes, they are not prominent, they are brief relative to the duration of the delusional periods, because we want to differentiate this from schizoaffective disorder. And somebody might be bipolar and have delusional disorder. You don't see them diagnosed together a lot. We see a lot of schizoaffective diagnoses. One of my favorite things I've ever seen in writing in court paperwork was from a psychiatrist I used to work with, who wrote in a patient's discharge packet, so-and-so was diagnosed with schizoaffective disorder, in parentheses, which he may or may not have actually had, or it said like, comma, probably incorrect, as this is most often an incorrect diagnosis. And I'm like, go you, buddy. Like, everyone should aspire to the day where you have enough initials before or after your name, or you can put things like that in writing and hand it to a judge and not care. Like, that's great. But you will see schizoaffective diagnosed even if they don't meet criteria, because the person might have something like, maybe they've had a manic episode and they also have a delusion. So things get a little sticky there. And as always, it's not because they're on drugs, right? Or some other kind of issue, right? If the delusion is purely that they think their nose has turned into a carrot, that's probably body dysmorphia. We've been over those already. So lots of nuances there. Types of delusions. So there are lots of other types of delusions. These are the ones that you can specify based on the DSM. Erotomanic, that would be like the patient I mentioned. There's a great example of this, probably one of the best examples I've seen. One of you made a document, right, of films and stuff. Yes.
Oh, yeah.
I'm sorry, I don't remember your name.
It's okay, Jess.
Jess, okay. The film is He Loves Me, He Loves Me Not. It's a French film with Audrey Tautou from the early 2000s. And if you want to see what delusional disorder looks like in action, that is the best film, because it is clinically accurate and it's not, right? Add it to the list. I will do that. He Loves Me, He Loves Me Not with Audrey Tautou, also known as Amélie Coutan, and she's been in a few less than satisfactory American films. Yeah, but anyway, great film. But it's a really great look because it's clinically accurate and it's not presented as this sort of like, ooh, scary kind of thing. It's certainly nerve-wracking, but it is accurate of an erotomanic delusion. Grandiose, kind of self-explanatory there. Jealous. This is an interesting one. You don't see this diagnosed frequently because a lot of times people that present with these sorts of delusions are in for other things like couples therapy or sex therapy or these other issues. And the DSM sort of specifies that jealous delusions are about perceived infidelity, which is very, very specific. And this is not somebody who's paranoid because they've actually experienced infidelity. This is a person who very truly believes that there's infidelity happening, even though it's not. And they have all this sort of evidence. This is one of those that's sort of in the discourse right now being debated of, is this a mental illness or is this some sort of abuse behavior or is it both or is it neither? And all of that kind of thing. Is it a control tactic? And just like we talked about last week with personality disorders, what it really comes down to is how much does the person truly believe this versus how much of it is sort of purposefully manipulative, right? And how much of it is purposeful but unconscious. And if that's the case, do they purposely believe it or not? Things just aren't that simple. Persecutory. Let's see. Another gentleman I worked with at the prison had this belief that he was incarcerated because he was being silenced by the media. This was before the great debacle of 2016 that we shall not mention because we don't get political in this class. But he genuinely believed that the specific writer at the Oregonian was talking to him. There was some erotomanic stuff there as well. He believed that they were in love and that she was secretly communicating through her newspaper articles. And then that turned into, why does she have a restraining order against me? Well, it's because she feels like she has to hide our love. Why did the police come when I left a birthday cake outside of her door? Why did I get trespassed from her husband's doctor's office? So on and so forth. And there were additional delusions that were integrated into the delusional framework to make up for that. And continued to have these beliefs, would order the paper, would come waving it at me, see, this, see what she wrote, this references me. And it would be about something completely unrelated. The poor woman, I won't go into HIPAA, but it was very much had nothing to do with mental illness, had nothing to do with anything this guy was into. It was completely random and he chose her, whatever. But the persecutory piece was very, very prominent because he was writing the governor, I've been incarcerated because these people are after me. These people are he believed that she was in danger, just all of this stuff. And I'm like, this poor random journalist. Like it was all over the place.
So they kind of believe like the world is against them?
Yes, but there's typically, as opposed to something like paranoid personality disorder, with a persecutory delusion, it's usually something very, very specific, as opposed to general paranoia. So this guy, that was his only delusion. Everything else in his life was fairly normal. But this one just kind of popped up. Same thing with our airport Romeo. No other, there was some other personality type stuff and some grandiosity. For instance, he played music and would say, I've gotten hundreds of thousands of listens. Let's go look at my SoundCloud. Okay, let's go look at your SoundCloud. We go and look at his SoundCloud and there's 100 people and all of them are him. Okay, where did all those views go? That's so interesting. Like you're telling me that you have this record deal that your girlfriend on TV is helping you with. And so those delusions tend to feed into each other, right? Now, it's been blocked now because she doesn't want to be associated with me because of her fame. And I'm like, okay. It didn't help that the song titles were things like, you can't make me take my meds. Or, that sort of thing. Like, buddy, just, don't. Pro tip, don't send women music about how you don't want to take your medication anymore. It's not an effective, doesn't work. Yeah, anyone, just don't do it. So these are all those definitions. We already talked about that. Somatic, we've talked about somatic before. And again, we want to differentiate this from certain types of somatic disorders, where here the delusion is typically more concrete. The person believes that a body part has been removed, or there's something inside of them that isn't really there. My bones have been replaced with glass. My bones have been replaced with metal. I had a really fun one at the state hospital where it wasn't that others were lizard people, it was that he was a lizard person and he believed that there were scales and you couldn't see them. And again, it wasn't a hallucination. He would say, well, you can't see them because I haven't, ripened yet, or whatever phrase he used. So on and so forth. But it was this very strong belief. And the poor man would not dress appropriately for things like the weather because he genuinely believed that he was cold-blooded. And that is problematic, right? Like, it's the dead of winter, we need to take care of that. Or it's very, very hot outside, I need you to drink water because like you're gonna die when it's 104 degrees and all that stuff. So, and then mixed type, if they have multiple, but one is not dominant. Oh, there you are. Whoa, that's really big. Unspecified. If it's not clear. So this is when the person has delusions, but it doesn't fit into one of those neat little categories that the DSM has decided are the most common types. There are other types of delusions. If you look at ICD, there are other types of delusions. If you read books about delusional disorder, you'll find other types of delusional themes, all of that sort of stuff. And so for DSM diagnoses, we would call it unspecified. Bizarre content. So bizarre would be the example they give. That would be an example of a somatic delusion. A non-bizarre thing would be something like that TV star's in love with me, because that is plausible, right? Because TV stars are human beings and they fall in love with people. It would be very, very different if you said that TV star is a lizard person and she's going to take me to her planet, and names a planet that doesn't actually exist, right? So bizarre versus non-bizarre, it's, this sort of whether or not it's plausible. And you get to subjectively decide what that means. If it's based on somebody's very real experience, for instance, I had a client at the prison who had several head injuries, had several head surgeries, and had schizophrenia, and he believed that his voices originated in a chip that had been implanted in his head during one of his surgeries. He also had head pain as a result of one of his surgeries. And so it was based on a true experience he had. There's no chip in there. We've gotten MRIs, we've shown him the MRIs, and that's where the additional delusions come up. But because it was based on this very real experience of, I have pain right here, I didn't have it before the surgery, therefore it must be this, we would call that non-bizarre. But if it's something that we as a society have decided is completely implausible, like you've been abducted and your organs removed, so on and so forth, that would be considered bizarre. You guys learned about Capgras delusion in any of your other courses? Capgras delusion. So Capgras, CAPGRA'(S), possessive, is the belief that one's parents and or family members have been replaced by imposters, and it's common enough that it has a name. Would you consider that to be bizarre or non-bizarre? Okay. Yeah. Well, and this is where that subjective piece comes in, right? Because it's common enough that we have a name for it. And so would we consider that to be bizarre? Or let's say, your book lists examples of folks engaging in certain spiritual practices where they believe that they've been possessed by an animal or a demon or something else. Would you consider that to be bizarre or non-bizarre? And a lot of it really just does come down to that sociocultural piece. If it's part of a normative spiritual experience, we would not consider it a delusion at all, unless it starts taking over the other parts of their life. So it's, there's a lot of subjectivity here that you can. Yeah, exactly. You get to decide, right? You as the clinician, you have the power.
Is there any primary source on delusional disorders that you found?
Lots and lots and lots of research papers, but not one singular, because delusions have historically been considered parts of other issues. And so you'll see delusions referenced even in really early writings about things like hysteria or all these other, sort of arcane diagnoses, but there isn't any sort of first, first discovery of delusional disorder, but you will find things like primary sources, research papers, and early writings on specific delusions.
That's really
Yeah. Yep. So specifications, these are going to be very similar to all of the other psychotic disorders, because first episodes compared to multiple episodes, there are a lot of different prognoses based on whether or not it is the person's first episode. And we'll talk about that more when we get to schizophrenia. And as usual, you are wanting to diagnose accurately what you are seeing the person for that day. You also want to be able to track progress. Let's say we've started treatment and now they're in partial remission. 6 months from now, maybe they're in full remission. It's a good way to just kind of, track that and justify to insurance companies, so on and so forth, why they're paying them to see you, why they're paying you to see them rather. So pretty low prevalence. One of the arguments for this is because there's a lot of misdiagnoses, and some of that is very much socio-political, cultural, etc. We see schizophrenia diagnosed a lot because folks that have a schizophrenia diagnosis tend to have access to additional treatments that delusional disorders do not. Some of the things that differentiate the two, if the person is treated, say, with antipsychotic medication and the delusion persists, if the person does not respond well to cognitive behavioral therapy for psychosis and the delusion persists, that's usually an indication that it is a delusional disorder and not, in fact, schizophrenia. And you rarely see diagnoses change. I've had lots of people say they have schizophrenia because they were told they have schizophrenia, and it turns out they don't have schizophrenia. It was something like a short-lived psychosis or a brief psychotic episode or an attenuated psychosis, which was just added to the new DSM, or postpartum psychosis, or one day they did a lot of meth and they got stuck that way for a while. Those are all things that get misdiagnosed. Yeah. One thing here is the persecutory piece and the correlation with increased risk for dementia and other neurocognitive disorders. We haven't gotten to the neurocognitive disorders yet, but one thing, and if you have any experience with family members or been around folks that develop dementia, you will see a lot of this sort of paranoia, right? These persecutory type beliefs. Family members are stealing with me, you're after my money, all of these very sort of normative, non-bizarre, what we might call paranoia, but to the person experiencing it, it's a very real fear. And so there's thought to be an etiological link between the two. Let's move on. Brief psychotic disorder. So, person has psychosis and it happens for less than a month. And what does that mean? Why would I diagnose this as opposed to something like schizophrenia, provisional? Or yeah. Or documented. Yep, exactly. So there's not been enough time, or here, we typically see brief psychotic disorder diagnosed after the fact. You might see somebody with a schizophrenia provisional diagnosis, and then they're in the hospital long enough and it goes away on its own. And you're like, well, that's interesting. Schizophrenia is episodic, but there are still, typically you still have negative symptoms. Even with treatment, the negative symptoms persist despite things like antipsychotic medications, therapy, all that stuff. Brief psychotic disorder is related to other issues. So they say typically precipitated by trauma or stress. One could make that argument for any of the psychotic spectrum diagnoses. And you will see this, if a person has had a very, very acute trauma and they experience psychosis for a few weeks and then it goes away once the, sort of acute stress response has diffused. You might also see things, this could be something like due to a fever, right? In which case we would say psychosis due to another medical condition, but maybe we don't know. And this could also be something that people experience because they are involved in some sort of organization or experience where they do develop these really strong beliefs. And then once they're out of that experience, it goes away. You see this used a lot for folks that have been involved in abusive groups of various forms, where they persist in having those experiences, and then in the absence of the stimulus, those beliefs tend to change. So they have all the things that schizophrenia has in criterion A, and then it goes away. Not very well understood. We have lots of sociocultural things, like all the things I just mentioned, that we think can cause it. Otherwise, not a lot is known. It can be a precursor to schizophrenia. Some people will describe having psychotic episodes early in life, and then they have nothing, and they're fine, no negative symptoms, nothing for years, and then schizophrenia fully emerges, but it doesn't have to. Criterion C here is the one to pay most attention to, because there are so many different things that can cause psychosis, like medical conditions, substances, all that stuff. Right now, there's a lot of research being done on COVID as a potential link to psychosis. There's been a lot of research on viral causes of psychosis already, and COVID is just kind of the latest and greatest, like, hey, look, here's more evidence that this is a thing. The general school of thought is that the person already has some sort of propensity or genetic predisposition, and then the virus kind of flips the switch on, but no one really knows yet. When we get to schizophrenia too, we'll be talking about this guy, Fuller Torrey, who's an interesting, controversial fellow who started doing lots of research on viral links to schizophrenia in the 70s. So things to pay attention to. So specifications. If it's due to a trauma, make sure you write down that it was due to the trauma. Postpartum onset. This is a fairly new development because it's something that's been happening for a really long time, but people didn't start taking seriously or really treating until the last 20 years or so. Everyone's heard of things like postpartum depression, but postpartum psychosis is also very, very common, very much a real thing. That one is interesting too, because I don't remember if it was added to the DSM-5 TR or not, but there has been discourse around whether or not we would consider postpartum psychosis to be brief psychotic disorder, because sometimes it does last longer than 4 weeks, but it is still very clearly postpartum related. So there's lots of debate there. Or let's say the person has an episode that lasts 4 weeks and 1 day. Does that mean they have schizophrenia? Probably not, but we're going to use our best judgment. Severity. This is a really fun quote from the DSM. We are not going to go through the actual assessment because I've been told that we don't do that in this class, and it's in the book. There are lots of good videos out there on how to do them. Yeah. A lot of this also comes down, though, as usual, to kind of use your clinical judgment, right? How much is it impacting the person's life? How much distress is it causing them? That kind of stuff. And you don't always have to diagnose severity. I don't see a lot of severity diagnosed or added to a diagnosis unless it's like really, really severe, right? If the person is catatonic and they've been that way for months, then you might see catatonia, severe, because it sends some, it's communicating to the next clinician that that's what's going on. But with most schizophrenia and, psychosis spectrum diagnoses, you don't always see an actual specification for severity. But there is a handy dandy assessment in the DSM. So fairly common for first onset psychosis, and that's why we want to differentiate between, schizophrenia, first episode or acute episode versus brief psychotic disorder. Most people who experience psychosis, they never experience it again. It's one of those fluke things that can happen, right? Lots of people have heard voices and not realized it. Lots of people have seen things that aren't there and not realized it. So there's sort of this spectrum, right? Deciding what's a hallucination, what's not a hallucination. Most people will describe experiences in which they could have sworn they heard someone talking to them and they weren't. that's a hallucination, even though we don't like to acknowledge that that's a hallucination, but that is a hallucination. Where you know that you heard that person say something, but they didn't. No one else heard it. Doesn't mean you're having a psychotic episode, but that's just an example of things that could look like psychosis as this sort of normative human experience, right? So point here being that lots of people have a brief psychotic disorder / episode, and it goes away.
Said you brought up what that's like of like how someone could be gaslit into
Oh yeah, absolutely. This is very similar to say something like Stockholm syndrome could be considered. Is that a delusional disorder? It's not in the DSM. What would we call that? You know? Temperament might play a role. So when we talk about temperament again, we're talking about these what we perceive to be innate personality traits, things like disordered personality traits, schizotypal type traits, suspiciousness, neuroticism, things like that are correlated with brief psychotic disorder. And again, not a lot of great research there. Schizophreniform. So again, something that we don't see diagnosed often, even though it's probably common. This is the person who, brief psychotic episode, 4 weeks and 1 day, right? Do I want to say it's a brief psychotic episode or brief psychotic disorder, or do I want to call it schizophreniform? Totally up to your clinical judgment. A lot of it comes down to, do I think this person needs continued treatment, or has it already happened and bam, it's over, and now we're learning how to cope with the trauma of the fact that you just had a psychotic episode. So different things to consider there when making, between the two diagnoses. But the technical cutoff would be, is it 4 weeks or is it more than 4 weeks? More than 6 months, then it's schizophrenia. Okay, fine. So most folks that get this diagnosis have pretty good functioning, and a lot of that is because it goes away so quickly. What the DSM does not differentiate is, does it go away because of treatment, or does it just go away? And so that also comes down to your clinical judgment. If this person presents with psychosis and I stick them on Haldol and they never experience it again because they're on Haldol the rest of their life, how do I know whether or not it was truly schizophrenia? And so there's a lot of balancing that goes on there. There's a lot of ethics that goes on there. Should this person be on a medication for their entire life? If it's, it can be a debilitating medication or some other kind of treatment that doesn't feel good all the time. Or do I want to take them off and see what happens? Oops, hey, look, you actually have schizophrenia. And then there's more harm there. So a lot of the questioning that you'll do with your clients will be sort of retroactive, right? How long has this been happening? How long has this specific symptom been happening? Did you have any of these other precursors as a kiddo or as a teenager? All that sort of stuff, because, we can't do things like experiment with our clients and see, sometimes people do if the client chooses, I'm going to stop my medication, see what happens. But that's something that they get to decide, right? So when you're diagnosing, you have to work really closely with the other providers and find out about what other treatments they're doing. Are they on antipsychotics? Have their symptoms gone away because of that? Or have their symptoms gone away because it's cleared up and they were having, a schizophreniform type experience and not the sort of long-term prognosis schizophrenia. The other thing is that you will not have if there is treatment, it will clear, where's my mouse? It will clear up the positive symptoms. It will not clear up the negative symptoms. So you will meet lots of folks who are on antipsychotics and their negative symptoms are still very much prominent, in addition to the side effects of different medications that look a lot like negative symptoms. So all of these are the same as what we saw with brief psychotic disorder and what you will see with schizophrenia.
Are these types of clients able to manage and take their medicine consistently, or do they need assistance with that, or does it just depend?
Depends. There's a lot of thought about that. There are sort of these two very competing schools of thoughts. There are the equalitarians of the world who are very big on mandatory treatment and this idea that we have failed folks with mental illness because they don't know that they're sick and all of this. It's a much more sort of paternalistic point of view, but also a very sort of realistic point of view when you walk out on the street and you see lots and lots of people suffering because they're living outside and they can't take care of themselves. And then you have the other end of the spectrum, you know, the Thomas Zazzes of the world, who believe that mental illness is 100% entirely societally contrived and medication is always unethical, and, you know, all of these other sort of, well, he doesn't believe it's always unethical, but is much more adverse to the idea of mandatory treatment. So it really just depends. There are lots of folks with schizophrenia that can have really good lives if it's caught early enough, if they can find, much like, you know, with trauma, if they can find some sort of meaning with it, and just depends on how it progresses. It's different for different people. Yeah. Schizophreniform, sort of by definition, has a better prognosis because it goes away after 6 months. So if we want to get pedantic, yes. We have ruled out that you're not schizoaffective because they've never had mood episodes concurrent with the positive symptoms. And it's, as usual, not because of drugs, not because of medications, not because of another medical condition. One of the main reasons I brought this book is so folks can take a look. Tori, for as problematic as his work can be, he's a researcher and basically puts out a new edition of Surviving Schizophrenia every few years with all the research. So he has like a 3-page chart of every single medication that has ever been documented to be linked to psychosis, and the study and the citation and all that kind of stuff. So be aware that there's lots of information out there that isn't in your book and isn't in the DSM. Here's a fun one. Is pregnancy a medical condition? Is pregnancy a medical condition? Would you consider, don't you laugh, would you consider postpartum psychosis to be psychosis due to another medical condition?
I thought you meant just being pregnant.
That's the question though, right? Think about this sort of medicalization of, again, normative human experiences like menstruation or childbirth. So that's kind of that whole medical model versus non-medical model thing that we could get into. Yep. And there's no correct answer because no matter what, somebody loses, right? Maybe. Yeah, you know, and it's contentious. I have a coworker at the state hospital who tried to get on disability because she had an 11-pound baby and she's like 5'2". Yeah, girl, whatever, dude. But she tried to get on disability because she had a doctor's note saying like she cannot go on the unit because she like has hip problems and shouldn't be using stairs and is at risk of further injury if she were to be assaulted by a patient or a staff or whatever. And the claim was denied because they did not believe that pregnancy was a disability.
Wouldn't it be better to put something like that on that desk and that option? Whether she chooses to keep everything.
I don't make the rules. Yeah. But that's kind of the language that we really want to be careful about is what do we consider to be a disability? What do we consider to be an illness rather than a condition or an experience and all that sort of stuff. So, yeah. All right. Catatonia. There are 2 different diagnoses for catatonia in the DSM. First one here is catatonia associated with another mental disorder, and that would be if you are going to add a catatonia specifier. You typically, I've never seen a catatonic disorder diagnosed by itself. But again, that's coming from an inpatient setting where, you know, what else is going on. This is listed in the section in the DSM under schizophrenia and other psychotic disorders because previously in the DSM-4 TR, we had subtypes of schizophrenia, and one of them was catatonic type. And catatonia can exist with other things. I had a patient at the state hospital who had depression with catatonia. to the point where she had to end up getting involuntary ECT, which is not a thing that you see very often in this decade or century. And it was effective. Not the greatest option. But for someone who is quite literally wasting away, and they've been that way for months, fortunately for those of us who are LCSWs and soon to be LMFTs and LPCs, you don't make those calls. So, you get to sleep at night, not having to worry about whether or not you made the good choice of zapping your patient in the face. I laugh because it's sad. So catatonia, everyone knows what catatonia looks like, right? There are lots of videos out there, folks that are catatonic, and be careful with them because not all of them are super ethical. So for example, waxy flexibility. Please don't go around to your catatonic patients and put their arms in weird positions and leave them that way because that's mean, okay? But it's a thing. You will see lots of photos. Yes, but we see these things, right? And we see these things even for folks that are well-intended, right? If you look at old psychiatry books, you will see lots of photos like that because they are demonstrating this is what catatonia looks like. But don't do that. We know what it looks like. We figured it out. You don't have to do that. Let's see. Catalepsy. Have you all seen Young Frankenstein with Gene Wilder? The scene where he punches the guy and the guy just is there and doesn't respond until after he removes the little head clamp thing. Yeah. It's at the beginning. He's in the big lecture hall with all his students, and he's got this poor gentleman.
Oh, yeah.
Yeah. He shot himself in the leg. Yes, he punches the gentleman repeatedly and there's no startle response. And you're like, cool. So that's what catatonia looks like. Due to a medical condition. So criterion A, didn't want to type them all out again. So all the same thing, and it is because of a medical issue. So kind of self-explanatory there. This could be a neurological issue. This could be a fever. This could be all kinds of things that could be associated with catatonia. And one of the main reasons this is in here is because oftentimes you will have folks that are presented in the emergency room with catatonic type behavior and they're sent immediately to psych when there's an underlying medical cause. And that's where you add this diagnosis and you say, shame on you. This is catatonia due to another medical condition. Go figure it out, right? So it's a useful diagnosis in that way. It would also be, let's say you have somebody who has depression with catatonia and they also experience catatonia when they're not having a depressive episode. Or let's say they have schizophrenia with catatonia, but they have a catatonic episode not during a psychotic episode. You might then consider this to be due to another medical condition if you decide that you want to consider the other mental disorder a separate medical condition, and if the catatonia predominates the clinical picture. Unspecified catatonia. So this is the person where they're catatonic and we don't know why, and let's figure it out. Lots of different coding here, and it's all based on what kind of catatonia they have. Is it speech? Is it movement? Are they unresponsive to certain types of stimuli? Are their spinal reflexes intact? You do the little tap thing and see what happens. That's a spinal reflex. It doesn't go to the brain. That's a very different thing than if they do or don't have them. We've done lots of experiments on folks with spinal injuries in various parts of the brain and various parts of the spine to see what happens. Also, a thing. Attenuated psychosis syndrome. As of publication, identified as a condition in need of further study and is in the new DSM, which I don't have details yet because I ordered it and it has not yet arrived. So please don't feel like you need to do that because they're very expensive and you will not be using them for a very long time. Wait a few years and buy a used one. I ordered one because I have a private practice and it's tax deductible and it's my job to know things. So this is going to be an interesting phase, especially in psychiatry, because we're probably going to see it sort of butt up against things like schizophreniform or various personality disorders, or say a trauma-induced psychosis, other thing. It's also a diagnosis that's been pushed for really, really strongly by folks in the mental health community, particularly clients, client family members, organizations like NAMI, et cetera, because it's meant to really open up access to treatment for folks that don't meet full criteria, or for folks who are at risk and need early treatment to avoid developing, something more serious or something more, something that interferes more with their life. So it is in the 5TR, and when it arrives, I will attempt to get the scanner to work, and I will send all of you the criteria, because I know you're all super excited. Rick is a really cool snail guy I found over the weekend. Isn't he cute? Right? The neat little dude. I put another snail next to him just to see what they would do, and nothing happens. I came back like 20 minutes later and neither of them had moved. And I'm like, why? I mean, I didn't sit there and watch them, but I came back and I'm like, you guys are boring. Like, figure it out. Yeah. Like a snail parade.
Yes, no, they weren't in order like that. I don't know if they were like mating or what. I mean, I couldn't tell, but they were all there.
Depends on how you want to define climbing up a tree.
They were going.
Talk about schizophrenia. Sundance. It's art. Come on. You're all gonna go home and watch all the rest of them, aren't you? Yep. Yep. So here is your book's definition of schizophrenia. Kind of vague. A broad spectrum of cognitive and emotional dysfunctions, including delusions and hallucinations, disorganized speech and behavior, and inappropriate emotions. Much simpler, sort of more concise, what I would argue more scientific way, although as we just witnessed, science can be subjective. Positive symptoms, negative symptoms, disorganized symptoms. Schizophrenia has to have, right? Yeah, schizophrenia needs to have all three. And it doesn't always. So you will find lots of stuff out there, particularly if you follow like Mad in America or some of the other sort of sociocultural view of schizophrenia type schools of thought, where you will see disagreements among different people over whether or not schizophrenia has to include disorganization, for instance, or whether or not it has to include catatonia, so on and so forth. And so again, we've eliminated the subtypes and have considered it to just be a spectrum with appropriately labeled subtype or specifiers. So a little bit of history stuff here. So Emil Kraepelin is the first person that is most often attributed to, that's not the right way to say that. The first person that schizophrenia has been attributed to, and prior to that, actually, one of Kraepelin's contemporaries, Charles Pick in Prague, talked about hebephrenia, and there were some differences. So at first this was thought to be, and dementia praecox was used more predominantly because Kraepelin was in Germany, and that's where a lot of work was being done. So a lot of it is just, the history stuff that was happening at the time. So anyway, so dementia praecox, dementia meaning dementia, praecox meaning early. Precocious is the same root word. It comes from a Latin word that I don't remember that means early ripening. And the literal definition is peaches or apples. And so the term was early dementia, and it was because of these experiences of forgetfulness that could now be attributed to disorganization, paranoia that we see people with dementia develop. And so what was thought was that this was dementia. It was just starting in early adulthood and not late adulthood. So that's what it was called. Later on, people figured out that that was not what was actually happening, because the brain of a person with schizophrenia looks very, very different than the brain of a person with dementia if they only have one or the other, right? Because obviously people with schizophrenia can also develop dementia and so on and so forth. So the early subtypes were catatonia, hypophrenia, and paranoia. Anybody remember what schizophrenia is from their book reading? Because I know you all did lots of reading over spring break, because that's what all normal people do over spring break. What's that? Not in the DSM. Any ideas? Any ideas? So this was essentially what would later be what we look at, this more disorganized presentation, the speech, all that kind of stuff. The big difference between Kraepelin's early work and Pick's early work is that Kraepelin used dementia praecox to sort of categorize all of these subtypes, whereas Charles Pick really only looked at hypophrenia. Eugen Breller introduced the term schizophrenia in 1908. He actually introduced it in 1907, but he first used it in a lecture in 1908, which you don't need to know, obviously, but I think it's interesting. And this was really the first time that you saw all of these different types of symptoms being described as one category. So this is a pretty old diagnosis. Bleller's early writings are really, really fascinating. He studied, he was one of the psychoanalysts. He studied under Freud. He was a contemporary of Jung. Lots of interesting writing there. He was also the first to distinguish between different categories of symptoms. So he was the first to point out both the positive symptoms and the negative symptoms. He was one of the first to describe this sort of episodic nature of the diagnosis. Couple of differences. He was really the first to point out, like, this is not the same thing as dementia, because it's not necessarily the sort of lifelong deterioration that you see with dementia, right? Like, dementia gets worse, sort of always. You can slow it down, but it's always going to get worse if the person lives long enough, right? That's one of the things that happens with dementia. There is very literal sort of organic deterioration of the brain that leads to the dementia. Whereas with schizophrenia, for a while, it was thought that it got worse, just like dementia. And there are still a lot of folks out there who will tell you that it gets worse. There are schools of thought who believe that each psychotic episode will be worse than the previous psychotic episode, or more intense or more damaging in some way. There's a little bit of research for that, but it's not clear if it's because there's something organic happening in the brain such that the episode such that these subsequent episodes are etiologically linked to earlier episodes that are making them worse. It's more likely that it's because it's going untreated, and it's because the person is kind of getting deeper into their delusional framework, all that sort of stuff, right? You can see how that can happen. So Weller was the first person to say, like, no, this isn't necessarily this sort of lifelong deterioration, so it must not be dementia. So the reason this is relevant is because our definitions of schizophrenia haven't changed a lot since the early 20th century. The biggest change has been in the belief that the course was deteriorating over time. And a lot of that has to do with the development of antipsychotic medications, primarily Thorazine in the 1940s. And like, oh, hey, look, this thing's treatable. People don't have to just get worse over time. Despite all the waterboarding and electric shock and, insulin-induced comas, so on and so forth. Oh, look, they're not getting better. That must mean that it gets worse over time. So lots of change there just based on available treatment, and you're laughing, but that's very much a real thing. Surprise, they didn't get better. I wonder why. Yeah, Tori talks a lot about some of those early treatments. But again, a lot of that had to do with this belief that there was some organic dementia-like cause. Not that you should do that to grandma either. So our understanding of the course has changed a lot, and our understanding of the onset has changed a lot. There's more and more and more research showing that there are these early signs as early as young childhood that may or may not be predictors. And I say may or may not because there are lots of things that people do in childhood that, almost everyone with schizophrenia will tell you that they've had experiences in childhood, but a lot of the experiences they describe are things that lots of children experience that don't develop schizophrenia. And so it's one of those sort of researchy things. That's where the attenuated psychosis syndrome comes in, and drawing the line between, say, magical thinking, that's just kind of a normal part of childhood, compared to, say a 13-year-old who believes they can read minds, and so on and so forth. What we used to consider psychotic behavior, there was a lot of overlap between folks that were experiencing what we now know to be manic episodes versus psychosis. So there's some change there. Let's see. When somebody is engaging in psychotic behavior, it's also typically logical in some way to that person, right? I'm going to go cover up all the vents because that's where the voices are coming from. So to an observer, it might appear to be irrational behavior, but to the person experiencing it, it makes sense. If that's where the cameras are, where the voices are coming from, I'm going to cover up the vents. So there's a logic there. The inappropriate emotionality piece, this is more, when we say inappropriate, what we really mean is mismatched. So the person's affect doesn't match their emotion, or their emotion and their affect don't match the stimulus. So they laugh when they're injured, or they're sad and they respond with laughter, or vice versa. They're happy, they respond with what appears to be facial signs of sadness. Grandma died and they start giggling, but they're actually really sad, and they're telling you how sad they are, but they're giggling to the point where they're falling over laughing. So there's this mismatch there between the emotional expression, the emotional experience, and the stimulus, or all of the above. So lots of change there, because for a long time that was thought to be a moral failing, and now we know that it's because there is more of a neurological issue happening. What else? So actual DSM criteria for schizophrenia. At least 2 of the following, and at least one of them has to be one of the first 3. That is where things get really sort of contentious in the mental health community, because there are a lot of people who are like, so you're telling me that if I don't have delusions or hallucinations, but I have disorganization and negative symptoms, that's schizophrenia? And how can you say that that's schizophrenia when somebody else who only has delusions and hallucinations, totally different presentation, is also schizophrenia? And that's a great question, right? Because that can look totally different. And the answer to that is that typically over time, if it is true schizophrenia, different episodes will look different. So you might see, and as things progress, because it can progress if it's not treated, right? The person might start to experience more or less of one or the other, and they might experience more or less of one or the other at different times. Stuff like that. Functioning issues. This is where that socio-cultural sanctioning piece becomes relevant. Is it actually affecting the person's functioning? If the answer is no, they don't meet criteria on B. And who gets to decide functioning? There was a really interesting book that came out a few years ago called The Protest Psychosis. And it was, I don't remember what hospital she got records from. I want to say somewhere in Michigan, maybe. But it was essentially about this overdiagnosis of schizophrenia among Black men because of this perceived paranoia by white psychiatrists and the white mental health and medical establishments during a time of the race riots and very real things like the CIA and the FBI following people around because they were civil rights activists. But most people who come to a psychiatrist and say the CIA is listening to me, oh, you must have schizophrenia. And she does a really great sort of deep delve into that particular issue. And would that affect someone's functioning? Absolutely. Because it's a thing that's happening to them. And it's a thing that they're experiencing, or it's a thing that they're witnessing happening to their peers. And so there's a lot of stuff that you have to be really careful with. Again, just like with any other diagnosis, figuring out, is this culturally sanctioned? Is this a spiritual practice? Does this make sense in the context of what the person has been through? And that's how we would really want to differentiate between schizophrenia and, say, something like a trauma response. To further complicate matters, we know that trauma can induce schizophrenia for folks that already have a propensity or for folks that have a genetic predisposition. So there's all sorts of stuff there. Have any of you heard of Ron Unger? He's an LCSW out of Portland. He was diagnosed with schizophrenia at one point. He does tons of trainings, tons of talks on the trauma link with schizophrenia. And he takes a very sort of non-medical model, more on this spectrum view. That can be problematic for some folks, but very much like a non-medication, like, let's treat psychosis as a trauma issue and let's do CBP. He does lots and lots of CBTP training. So if you are interested in schizophrenia and working with folks with schizophrenia, his trainings are super, super useful, CEUs, all that stuff. At one point, he was even part of the Portland State, did an interpersonal neurobiology certificate, which I think Pacific has as well. And he was one of the professors for that. So really interesting dude, look at his work. Ron Unger. What's interesting about Ron is that he's very open about his experiences with psychosis and hospitalization, and again, takes a very pointed stance, but you will still see certain things that we would consider to be symptoms, right? And he'll talk about that, things like having a flat affect, all of that. And what does that mean? Why is that? Those things being used to kind of categorize what he now knows was a trauma response and all that stuff. So criterion B, criterion C. So again, it's happening for a long, long time. It is not schizophreniform. It is not a brief psychotic disorder, because this is something that this person continues to experience for months, right? Often years. The episodes. So they have to have at least one episode that lasts a month or less if successfully treated. That's where it gets fun. And if it got successfully treated, how do we know? I have no idea. Use your judgment, right? That's kind of the catch-all answer for I have no clue. Because how do they meet criteria if it's been? But one way to look at that could also be, let's say they've had multiple episodes that have gone on for more than 6 months, but maybe they haven't lasted a month because of treatment. And you do see this. You have a lot of folks who stop taking medication because the episode has finished. My symptoms are better. I don't need the medicine anymore. And then they're fine. And then a year later, they have an additional episode, or a month later, they have an additional episode, all that kind of stuff. You typically do see residual symptoms in between. There might still be this baseline paranoia. The delusions typically don't go away, and the negative symptoms typically don't go away. We have ruled out schizoaffective and bipolar. So we want to make sure, and here's where it's fun. Difference between schizoaffective disorder, with psychotic features, or rather bipolar disorder, with psychotic features, and schizoaffective disorder. With schizoaffective, and we'll get there here in a minute, they have to have psychotic symptoms during a mood episode, and they have to have psychotic episodes outside of the mood episodes. With bipolar disorder with psychosis, they can have psychotic episodes concurrent with mood episodes, and they also have mood episodes without psychotic symptoms, and they don't have psychotic symptoms outside of the mood episode. So there's like a Venn diagram there, and you get to pick which one you diagnose them with. And that's one of the main reasons why there has been sort of this overlap between bipolar disorder and schizophrenia historically, and why you see that in the historical documentation of both of those.
There a tendency for people to diagnose quickly versus
Yes.
wait
Oh,
for
yeah.
wait for a period of 6 months, year, 2 years.
Oh yeah.
Is there a reason for that? Is there benefits to one or the other, or is it just
Lots of reasons. In outpatient, working with the worried well, right, folks that have insurance, somebody shows up, in order for me to bill insurance for their session, I have to have a diagnosis. And that's a sociocultural, like an economic issue, because again, I work primarily with OHP clients. These are folks who can't afford to pay out of pocket for a therapy session. And so I have to make something up.
But you don't have to jump right to schizophrenia, you could jump to 100 other things.
Oh yeah. I use a
not
lot of,
slap
I use a
that.
lot of Z codes, right? Problems with family, you
Right,
know, but eventually insurances will want to see some sort of
I
diagnosis.
guess that's what I mean, instead of jumping to schizophrenia, which
Yeah.
tends to not ever be reversed, maybe doing something less
Oh yeah.
dramatic.
Yeah. Provisional
until-
diagnoses are there for a
yeah,
reason.
until It's really obvious,
Yep.
or
We-
they really need treatment, or get them
Yeah.
access to treatment or something, some benefit.
Yeah, and that's why provisional diagnoses, the best practice is to keep it provisional for up to 6 months, because at 6 months you should have figured it out, right? Or at least that's what people think, that they should have figured it out. You see this a lot in hospital settings where it'll be schizophrenia provisional, and then roll out schizoaffective, roll out substance-induced psychosis, roll out bipolar with psychotic features, roll out, you know, all of those things. Because, okay, I have to write down something so that I can justify why you're getting this kind of medication, or we're doing this type of treatment. But I'm going to list, just like all of you do with your case studies, I'm going to list what I think is probably the diagnosis. I'm going to call it provisional for up to 6 months, and then I'm going to list all of the other diagnoses I'm considering. That way, all the other providers that are working with that person know, you know, your train of thought. But yeah, absolutely. Or let's say right now, the big to do is with patients who are hospitalized under ORS 161370, which is the aid and assist law. You've probably seen it in the news, because the Department of Justice is now involved. It's a thing. OHSU is now involved doing a research study on why the Department of Justice is involved. All sorts of fun stuff there. In order for a patient to qualify as unable to aid and assist, they have to have there's a specific list of diagnoses of qualifying mental disorders that the legislature has decided qualify a person to go to the state hospital instead of going to jail or prison. One of those is schizophrenia. One of those is not, say, substance-induced psychosis. So you do see lots of folks get diagnoses that may or may not be accurate, because it might be the only way that that person gets the treatment, as opposed to being incarcerated. Lots of political stuff there, lots of cultural issues there. So yeah, things to think about, because those are the things that you're all gonna have to deal with in a few months when you graduate. Get out into the workforce and you're like, why is this person diagnosed with this? And you will have someone who straight up tells you, because that was my option, right? And that's not a fun space to be in. Oh, let's see. So we're going to roll out other things that look like disorganization, disorganized speech, thought disorders, etc. There is a very long and contentious history of autism being treated with antipsychotic medication. Yeah, so that's kind of why that was added to DSM-5, because it was becoming really problematic. Features. So fairly, and some of this, you'll see a huge range here, right? The general number you'll hear most is 1%, 1%, 1%, 1%. And we know from the research that all different studies have found all different percentages, and a lot of that is based on the sample, how we're diagnosing, all of that. Because if we're going off of an inpatient sample and extrapolating that to the general population, or even an outpatient sample, there's still people presenting for treatment of some form. Of course, they're going to see higher rates. Others are looking at, okay, well, we've rolled out all these other things, or maybe it hasn't made the whole 6 months, all of that kind of stuff. There are studies that no longer consider it to be schizophrenia because it's been in full remission for this long, and the person, maybe they haven't had an episode for a really long time. What do we call that? Let's say they had an episode, maybe they had symptoms for longer than 6 months, and then it went away without treatment, and it's been a decade. What do we call that? Doesn't meet any of the current criteria, right? So lots of different prevalence rates out there. Typically develops in early adulthood. There's some change here. We see it develop earlier among cisgender males and later among cisgender women. Not a lot of information as to why. There's some thought that it has a little bit to do with puberty. There's some thought that it has a little bit to do with different types of stressors. There's quite a bit of thought that it has something to do with trauma response, because it tends to be diagnosed among men more frequently than women. And most women who present with schizophrenia do have a history of trauma whereas not all men who present with schizophrenia do. So there's a lot of nuance there. Childhood cases are rare, not totally unheard of. And the heritability, here's what makes schizophrenia interesting and so researchable, is that it has one of the highest heritability rates of any other DSM diagnosis. So around 50, which means that if I take some monozygotic twins and I separate them at birth, the variance, about 50% of the variance appears to be due to genetic factors. That's a really, really, really high number, which tells us that there is something biological happening, something genetic happening. We also see, I guess I'm getting ahead of myself, this happen. Wrong slide. Huge, huge, huge change in risk based on degree of relative. So lots of information that lends itself to thinking that there's definitely some kind of genetic component. No one knows what it is yet, but there appears to be one. Let's go back up. All right, prognosis. Generally chronic, right? By definition, it lasts more than 6 months, that's chronic. A lot of people have impairments, and there could be lots of people that have schizophrenia that don't have impairment, and therefore we don't know that they have schizophrenia. Who knows? I've worked with lots of folks who are much, much older and are getting their first schizophrenia diagnosis because they've been surviving just fine throughout their life. I had an individual at the state hospital who was in his 60s and he was doing just fine. He lived on a property. His symptoms had not changed since he was in his early 20s. He ended up at the state hospital because the cops came to his house and he shot at them. Fair enough, right? Haven't we all? So never would have known. He was functioning fine by his definition. He had his own property. He could feed himself. He was physically healthy. He had also experienced some traumas, despite the fact that he would have met full criteria, say he had presented for treatment in his early 20s. Things didn't really get bad. The functioning impairment didn't happen until he lost his wife and then his mother. And so the impairment piece there, would he have shot at the cops 50 years ago? Probably, but he didn't. So whether or not we would consider that to be a functional impairment, if you saw the guy's house, it's iffy. Definitely, it looked like, something off of Pickers, kind of this hoarding, but he was an antique salesman. And so antique salesman. Don't know how much he was actually selling and how much he was just kind of keeping things about, but whatever. What's that? It's Eastern Oregon.
Oh.
Yeah. Whatever. Another person, and this is not a HIPAA thing because it was all over the news, another person who I believe is still at the state hospital who was very, very successful, owned several hundred acres, had a fully functioning farm, had a psychotic episode, killed his wife. Nobody knows why or how that happened. Some folks on that treatment team believe that he was a high functioning person with schizophrenia for a very long time until he wasn't. Other folks are like, well, maybe this was a brief psychotic episode, but there's really no way of knowing because we're doing some sort of retroactive questioning, right? Like, what was your life like before this? And complicated. So at any rate, most people don't do great because the nature of the illness is such that you're not going to do great. If you're experiencing hallucinations, and that affects your ability to do things like drive or be safe or take care of yourself, that makes sense. If you're experiencing delusions that affect your ability to work or do other things that we consider to be functioning in our society, that makes sense. Life expectancy is lower than average, and that's for lots of reasons. One of the reasons that your book doesn't mention that I think is fabulously ironic is the medical piece. So there's increased risk for suicide, increased risk for accidents, self-care may be poorer, whatever that means, increased substance use. We also know that treatment can be problematic. Lots of antipsychotic medications come along with a big red sticker for metabolic disorder. type 2 diabetes, stuff like that. And so one of the unfortunate truths of when you work with folks that are dealing with psychosis is like, listen, this medication might help you function, and you're going to have to exercise more than other people. You're going to have to be more careful with your eating than other people. You might have to go get a monthly blood draw to make sure that this medication is safe for you, especially things like clozapine and these other more intense, second and third generation antipsychotics. And they're getting better all the time, but that is one of the things that contributes to the lower lifespan, even though your book conveniently leaves that out. It's a thing. So a lot of it is working with the person and helping them figure out, like helping them decide what's going to be better for them. Can I live with these symptoms versus can I deal with these other side effects and all that stuff? That's where that sort of client self-determination thing gets important. Subtypes. Again, we don't use these anymore, but you will still see them all the time. Lots and lots and lots. You will even see them currently diagnosed with folks, especially in community mental health. Or older diagnoses, that sort of thing, people's records. Yeah, and they're useful. They're not used now because we know that folks don't really fit into these neat little categories, but they can be useful in describing what the person was experiencing at that time when they were diagnosed. Gender and culture. This says it affects males and females about equally, which is not accurate. That came from your textbook. The DSM gets into a little bit more detail, and the current research is a little bit different. That being said, we also know that diagnoses can be different based on gender. We talked about this a little bit last week with personality disorders. Folks that present with certain types of behaviors are more likely to be diagnosed with certain things based on things like their gender, our perception of gender norms, all of that stuff. Yeah. Earlier onset for males, we talked about that. Cultural factors. So obviously we know that lots of people have what we might consider to be psychotic behaviors that we don't pathologize. And when folks have done these sort of cross-sectional studies, they found that schizophrenia happens all across cultures at very similar rates, but it might look differently. The content of the delusions is going to be different. The content of the hallucinations might be different, but you are going to see things like disorganization. You're going to see things like catatonia. All of those things exist across cultures. It's really, really, really important, especially if you're working in inpatient, to have like interpreters that specialize in mental health, because often when you're dealing with something like disorganized speech, an interpreter will tell you what the person is trying to say and not word for word what they're actually saying. And so if you're doing an assessment and you're trying to do a mental status exam and you're not sure whether or not the speech is disorganized, this happens a lot where you'll be working with someone and their interpreter will say, well, hold on, what they're saying doesn't make sense. You're like, okay, but I need to know, or there might not be, but there also could just not be a direct translation, right? And so a lot of it is around figuring out what disorganization looks like for different languages, what different language patterns look like, how phonemes work, all that kind of stuff. So you can give a really good assessment and accurate assessment of whether or not that person's experiencing disorganization. Same thing with circumstantiality. If you're working with someone from a culture where storytelling is just part of how they communicate, you see this with certain native cultures. You see this with sort of old world European cultures, different age groups. You're like, okay, is this really circumstantiality or is this just sort of a normative, language thing? Yeah, absolutely. What's that?
More indirect.
Yeah, absolutely. So all those kinds of things. Same thing with affect, right? If you're working with someone from a culture where affective expression is much more exaggerated than other cultures, or vice versa, a culture where people don't tend to have as much facial expression, you want to take those things into account. Of course, the prodromal phase. Your book talks a lot about this. This is where you will likely end up seeing the attenuated psychotic syndrome diagnosed based on the new edition of the DSM. So what was previously sort of currently referred to as the prodromal phase, which we will probably start calling the attenuated psychotic syndrome phase, though that will not be on your exam because your exam is based on your book, but you should know. Really, really common. Most folks that you talk to with schizophrenia will tell you about other experiences that they had before they experienced all the symptoms. So it's not like they wake up one day and suddenly they meet full criteria for the diagnosis. Typically, they might start to have some slight delusions and then they develop over time, or maybe they have some slight hallucinations that develop over time and become more prominent over time. Or maybe they've always had negative symptoms and then the positive symptoms came later. They're all different things that people can experience that don't meet full criteria, but that are sort of these precursors. Magical thinking. How would you guys define magical thinking? This is something that came up a couple weeks ago when we were talking about autism, and somebody had mentioned like very literal magic. But when we talk about magical thinking, it's this really, really old term. Becker talks about it actually. And it's more, Freud talks about it, Jung talks about it, Piaget talks about it, folks that are into developmental psychology, all that stuff talk about magical thinking. And it's not so much a belief in magic as it is a belief in causality that is inaccurate. So things like, people will play little games, right? If that door opens at this time, it means this is going to happen, right? Like superstitions, that sort of thing. Yeah. Or the sort of classic example that the psychoanalysts use is, the child sees their parents behave in a certain way, and because they don't have theory of mind yet, they think that it has something to do with themselves, and they have thus exerted some sort of behavior or thought control over the parent or the other person, that kind of stuff. So you might see a little bit more of that with folks that are going to develop schizophrenia. And again, these are things that are, most people with schizophrenia talk about these things, but there are tons of people that experience these things that don't develop schizophrenia. So you don't want to go home and say, oh, my kid does this, it means they're going to get schizophrenia. It doesn't work that way. It's one of those umbrella kind of things that most children experience these to a certain extent. And the majority don't, 99%, don't develop schizophrenia, but almost all folks with schizophrenia will talk about these things, and they'll talk to you about the first time the TV spoke to them, the first time they heard that voice. And it's usually really, really young. Here's a fun diagram that I stole from your book. So what this might look like. Don't ask me what social impairments look like at gestation or birth, because I don't know. But again, I stole it from your book. So at least they started at 0 instead of at a different age. I'll give them credit for that. And this is fairly accurate. You typically see these more subtle type symptoms earlier in life, and then you really don't see the positive symptoms develop kind of full-fledged until later. Yeah.
That kid January.
What was it? No, I want to know.
There was like this girl named January as a baby, like looking around, seeing. And then I think the mom, it was like made up or something. I don't know.
Like a fictitious by proxy?
Yeah.
Interesting. Huh. I mean, maybe. I mean, babies look around at things all the time because they can't see, right? We've talked about that already.
Yeah.
And because there are shiny things and it's interesting, and you've been in the dark for 9 months and now there are interesting things to look at.
And she had imaginary friends.
I mean, who doesn't? Yeah. If you're 30 and have an imaginary friend, let's talk. But if you're 5 and you have an imaginary friend,
My niece is that we love lights and like fans. Like, so
yeah, totally. Yeah. Yeah, like I'm not going to say my kid has schizophrenia because they believe in Santa Claus because I told them Santa Claus is real, right? That's a culturally sanctioned thing. And that's also a great thing to bring up when we talk about treatment is psychosis is traumatizing. The beliefs, if you believe that someone is after you, if you believe that people are listening to you, if you have beliefs that things are happening to your body, that is traumatizing for people. And one of the hardest things to do with schizophrenia treatment is helping the person cope with loss, right? because they have these voices, they have this experience, and all of a sudden those voices are gone. And you have to help them figure out what to do about that because there's a loss there. Even if it's the loss of something that was unpleasant, it's still a loss for them. Even if there's this loss of, we had a patient at the state hospital who had all sorts of grandiose delusions. And after a while, it was like, he's not responding to his cognitive behavioral therapy, reality checking type stuff. So let's not so much play into it, but let's acknowledge that he believes that he's this very important person. And so we would correct him that way. Like, okay, but you're not the rapper in the video that you keep pointing out and saying you are, because it's clearly not you and because you're here, but he believed he was. So I'm like, okay, so you're this very important person. What does that mean for you? And if a person has those sorts of delusions and all of a sudden they find out it's not true and that's their entire identity, you have to help them with that loss. You have to help them figure out, like, okay, if I've spent my whole life believing that I am Christ or a prophet or a famous rapper or whatever, and now I'm on medication and all of those signs have now gone away, you have to help them kind of figure that out, right? Absolutely. Yeah. And that in of itself can be really traumatizing for folks. And sometimes we'll send them into another psychotic episode because their brain is very desperately trying to find evidence for those beliefs, right? It's like if you were to wake up any day and have like a Shutter Island moment, right? That would be traumatizing. It's a thing. Not totally accurate. And it's interesting, right? Oof. Yeah, I don't know that I would you know, I did have a patient who believed he was a psychiatrist, and we let him do things like write notes. And you know what? You looked at the notepad and it was scribbles, but it made him happy and it wasn't hurting anybody. Right. So why not? Yeah. Literally scribbles. And I'm like, what's that say? And he would tell me what it said. And I'm like, cool, whatever. That's fine. Causes of schizophrenia. So we know that folks have a genetic predisposition, and this is why one of the other reasons we got rid of subtypes is somebody who has a catatonic type or a disorganized type, their first degree relatives have an increased risk, but not for the same type. And that's why there's this idea that there's a connection between all of those different types of symptoms, because you can see different combinations and you see increased risk for all types regardless of the type. We talked about twin studies. We talked about this already. So this is one of the, schizophrenia is again one of the clearest examples of having some sort of genetic thing at play. We don't know what it is. Maybe it's temperament. Maybe it's something to do with the dopamine pathways, all of that stuff. Nobody really knows, but there's a very clear genetic risk, and it's based on some pretty concrete evidence. You know, the numbers are there. Endophenotypes. Remember that from your book? What's an endophenotype? You know what a phenotype is, right? That's all right. So phenotype, genotype would be something like, does this part of the DNA strand have a G, an A, a T, or a C? And a phenotype would be, what does it look like? What protein does it produce? The genotype would be the actual genetic sequence for having blue eyes. The phenotype would be the fact that the eyes are blue. So the phenotype is the expression of the gene. An endophenotype is basically anything that contributes to some sort of internal process. Endo is internal, like endorphin is internal morphine. Anything that's endogenous is internal, all that kind of stuff. So endophenotype. There are some genetic markers for different processes that are happening, and again, not very well studied. Most likely involves multiple genes, which makes sense because there are so many different things happening, right? There are things happening, there are the perceptual disturbances. We see things happening in the occipital lobe. We see things happening in the temporal lobe and the parts of the brain that are involved with the sensory integration. We see things happening in the limbic system. We see all sorts of different things happening, and those are all obviously different, you know, genetic processes. Couple of small things that the research has found. there does appear to be some issue with tracking ability with eyes, which makes sense if you think about certain types of visual hallucinations. You know, if I'm tripping balls on mushrooms and all the furniture is floating, it's because my eyeball muscles have slowed down, right? Same things happen with schizophrenia. We talked about this a little bit with cannabis intoxication, very, very similar. And that's one of the reasons why certain types of substances could be linked to schizophrenia or psychotic episodes in general, is because they're causing some sort of physiological change that relates to the hallucinations. Twin studies, we already talked about this. Adoption studies, kind of talked about that. Adoption studies are losing favor in psychiatric circles. They used to kind of be this gold standard, because obviously we're not going to do double-blind placebo studies on things like schizophrenia, because that's mean and unethical and all that stuff. And we are learning that adoption is problematic, right? You've been adopted. There's going to be attachment stuff. There might be trauma stuff. We also know that you can't rule out sociocultural factors, because most folks that are adopted tend to be adopted within the same group. Maybe they're adopted by a different family member, they're adopted within the same race group, all that sort of stuff. So adoption studies exist. There's lots of research, and take it with a grain of salt. Yeah. I love this sentence. This sentence comes straight out of your book. The implication being that if your parent has schizophrenia, that's inherently an unhealthy environment. So let's pick that one apart. It can be, but it doesn't have to be, right? The dopamine hypothesis. So this is more than a hypothesis at this point, because there's lots and lots and lots and lots of evidence for it. And so I would call it a theory, because it explains a phenomena. Most antipsychotic medications are doing something to dopamine pathways. And other things are happening, because even with those, we still see the negative symptoms, and we still often see some delusions. The delusions might be less persistent and more amenable to cognitive behavioral therapy for psychosis, but they still tend to be there. It mostly helps with things like hallucinations, catatonia, interestingly enough, stuff like that. We also see, this is fun, folks that are getting treatment for Parkinson's, the medications that are dopamine antagonists will have side effects that look a lot like schizophrenia, things like hallucinations and delusions and paranoia and all that sort of stuff, and vice versa. The agonist for dopamine, or other way around, the antagonist will, if you work with folks that are on antipsychotics, they can develop tremors, issues with the tongue, issues with the hands, that looks a lot like Parkinson's. And so it's very clear that dopamine has something to do with both, and that they are opposite in some way. And lots of other stuff is happening. That's just where most of the research is, because it's fairly simple to research, and there's a lot of data out there about it. Other neurobiological things. We do see changes in the brain, and it's not clear how much of those changes are due to schizophrenia versus how much of the schizophrenia is due to the changes in the brain. So it's that whole correlational thing. The early studies were all post-mortem. There are fMRI studies now, and there have been changes. So there have even been changes since when your book was written. I found another study that I stuck on one of these slides with the citation, where they found no difference. They did a very large scale study and found no difference between the brains of folks with schizophrenia and the brains of folks without schizophrenia. So not a lot is known. Most of those studies were done on inpatient populations that had either already had treatment or not, or folks that ended up in inpatient because of various other issues. And so lots to unpack there. Again, though, we do see less activity in the frontal lobe, specifically the prefrontal cortex. So there is this, first, it's a major dopamine pathway. It's involved when we talk about addiction, that the dopamine pathway that is involved from here to the sensory pieces, to the memory pieces, back here, up front again, that could have a little bit to do with sorting out relevant information versus irrelevant information. Maybe a person is hallucinating something that is there, but other people can't see it because it's so small. Maybe they looked at the lights, and because their brain doesn't differentiate the light spectrum the same, that's why that person's eyes appear to be red to them. There are all sorts of different ways of filtering information that we don't really understand, but we know that the prefrontal cortex has something to do with it. There's also that impulse control piece, where we see the, what we would call psychotic behavior, where the person isn't able to control certain types of behaviors like speech behaviors or disorganized thinking, all of those things. Viral infections, lots of different research here. So there is quite a bit of evidence that viruses during pregnancy are correlated with schizophrenia later in life. There is lots of evidence that early diseases of early childhood, things like measles, mumps, meningitis, are correlated with schizophrenia later in life. And now there's lots of new research coming out to this, again, this thought that the long haul COVID syndrome can be related to psychotic experiences and lots of other neurological experiences. So we know that viruses can do stuff to the nervous system. We just don't know what or why or how. Get vaccinated. Yeah. Spec studies. This is where it gets really interesting because we can narrow down really, really specific symptoms. So, single photon emission computerized tomography. I can't say the word, whatever. So, really cool stuff here. We know that when a person has auditory hallucination, the parts of the brain associated with speech light up. Sometimes the parts of the brain associated with hearing lights up. That's interesting because the person's hearing things, but they're not necessarily talking, and yet we see speech areas lighting up. What does that mean? Nobody knows, but it's interesting. So we know that there's something happening in those parts of the brain that are producing speech, whether or not the person's producing speech versus they're producing speech in the head. But we also know that when people with schizophrenia describe their voices, they describe them as being outside of the head. They might say the voice is in my head once they learn that it's coming from their head. But when most people don't have insight, they very much hear things outside the way that you hear me talking right now, as opposed to an internal dialogue. There used to be lots and lots of research that there were differences in gray matter. And a lot of that is because we see differences in gray matter based on things like antisocial personality or malnourishment and other poverty-related issues, because they were doing postmortem studies on folks that ended up in inpatient facilities / asylums in the early 20th century. And so newer research, there's a citation on there somewhere. No, there isn't. Where did it go? This one. Ha. And we see differences in gray matter loss in schizophrenia. Your screen doesn't look like mine. There we go. So lots of sort of contradictory evidence out there. So when you read, when you see these studies, go look at the actual study and look at what are they measuring, what's the population, what parts of schizophrenia are they diagnosing. So the SPEC studies are interesting because they're looking specifically at folks that are diagnosed with schizophrenia that are having auditory hallucinations, and they're measuring the activity in the brain during the hallucination, as opposed to just, let's look at the whole brain for somebody that has this diagnosis. Maybe they have hallucinations and maybe they don't, and trying to kind of draw conclusions from that. So there's all kinds of seemingly contradictory information out there. We're going to go with the DBT approach and say both things can be true, because DBT is great. And I like it. That's where some of those spots are, if you care. Things to know. I like teaching people about brain stuff because I think it's useful when working with clients, because they want to know, they want to understand. And I have a very firm belief that your clients are smart enough to understand. So why not teach them what's happening? It usually makes things make sense. Mhm.
Speech period versus the hearing area.
Mhm.
They compare that with someone, say, that was told to think specific thought. Is that differentiated from
Not in that particular study. So in the Broca's area studies, they would have folks essentially click a little button that says, when you start to have a hallucination, click the button, and that's when we're going to look at your brain and compare that to when you're not having hallucinations, and then compare that to other brains. But that's a good thought, because that would help differentiate the internal dialogue piece from the, the external hearing of voices. Absolutely. Yeah. The other thing that would be an interesting study would be to look at differences between voices and other types of auditory hallucinations, because not everybody that has auditory hallucinations hear voices. Lots of people hear music. Some people hear a ringing, some people hear a buzzing, some people hear flies. There are all sorts of very specific hallucinations people have. It's not always voices. So that would be something to look into. Is it always the speech area if it's a non-speech hallucination? I don't know. MRIs cost like $600. So paying for that with a large enough sample size for it to be meaningful, when you all get your PhDs, you can do that and come tell me about it, because it's interesting stuff. So in this particular study, they looked at Haldol and found that some of those areas changed. Right here, we are looking at some ventricles, which we're going to talk about down here. Your ventricles hold your fluids, and they're involved in lots and lots and lots of other things. And if they shrink or grow, well, I shouldn't say if they shrink, if they grow, other parts around them shrink. If they shrink, other parts around them grow. Things get a little weird. We see other things kind of fill in the gaps, all that stuff. We see fluids get leaky. You have lots of fluids. You're a bag of meat with lots of fluids. And yeah, we're counselors, right? We do feelings, not fluids. That's at least what I tell my clients. I'm like, get out of here with that. And you're going to still see lots of fluids, because that is the nature of our work. So have fun. Yeah. We know that we see enlarged ventricles and thus shrunken gray matter. And so maybe it's not an issue with the gray matter. Maybe the issue is actually with the ventricles. And we know that because when we look up here at what Haldol does to the ventricles, cool. Other neurobiological influences. So substance use, the DSM has a whole list of substances. Our friend Fuller Torrey here has an even longer list of substances. I like his list because it's not limited to illicit substances. We talked about this before, but the two main ones to look out for are THC and methamphetamine, which have very little in common, except for the fact that they can induce psychotic episodes for folks that already have a propensity towards psychosis or a genetic predisposition to schizophrenia. So if you have schizophrenic parents, please don't do meth, and be real careful with the weed, because that can be problematic for you. FYI, it is sort of a sucky reality, especially when it comes to substances that are more socially acceptable, right? I've worked with lots of people who are like, I just smoke weed with my friends and I don't understand why this happened to me and not them, because that is considered a socially acceptable behavior, especially in states where it's legal. And in states where it's legal, where we're now able to do more research, we're finding a stronger and stronger link between the two. So, yeah. Interesting. Yeah, that's very interesting. I haven't looked a lot at that yet. I will look that up. Yeah. Yeah, I know historically there's been this hesitation to do any sort of hallucinogenic therapy with folks that have a predisposition to psychosis. You probably all heard, like, don't do LSD because you'll get stuck that way. There's not any research that indicates that. It doesn't stay in your spinal fluid. You're not going to start seeing unicorns while you're driving down the street one day. It's a thing that parents tell you to scare you so you don't do drugs. But we do know that methamphetamine and THC can do that. Not get stuck in your system, but rather induce some sort of schizophrenia-like episode. And for folks that have a predisposition, can actually sort of flip those genes on. And congratulations, now you have schizophrenia. Not a fun thing. So the role of stress and also trauma. That's a thing for sure. We also know that, again, the trauma of having a psychotic episode can then lend itself to further psychotic episodes. We know that the trauma of the functional impairments that come along with psychotic episodes can also lend themselves to further psychotic episodes. There is lots and lots and lots and lots of information out there that is not accurate. So you will see lots of stuff that is very, very, very problematic. You see this a lot in early sort of like psychoanalytic schools of thought. This idea that if your mom was weird, maybe you're going to have schizophrenia. Or this idea that if there's some sort of moral issue at play, you know, if your mom is engaging in sexual behavior that is not considered to be normative in our culture, maybe you're going to have schizophrenia. These are completely unsupported theories, but you will still see them, and you will still see remnants of them in some literature and in the way that we talk about different types of behavior and the way we talk about different moral types of behavior, all that sort of stuff. Like the slide that we had earlier, that was pretty problematic, right? High expressed emotion is associated with relapse. What does that mean? Because wait, we just said that schizophrenia, folks tend to have negative affect. This tends to have more to do with distress tolerance and emotions that make sense in the context of something like having had a psychotic episode, like fear or anger, all that sort of stuff, just distress and tolerance. In general, which also has a lot to do with trauma, right? And cultural differences in expressed emotion, right? Like we want to make sure that we're looking at what is considered to be normal, what is considered to not be normal, and how are we measuring something like high expressive emotion? Yeah. Psychological factors. So these are things like personality traits, coping skills, all of those sorts of things. And the best way to put this, if we're looking at a model where we're talking about somebody having a propensity towards schizophrenia and then something comes in and flips the switch, it kind of makes sense, but only in the context of something like genetic factors, because we know that things like temperament tend to be inherited in some way, shape, or form, whether it's through learning from the parents, family, or whether it's genetic, nobody really knows. Medical treatments. So yes, we don't waterboard people with schizophrenia anymore. It doesn't work, it makes them worse, and it's mean. Don't do it. We don't put people into insulin comas anymore because sure, maybe they wake up and they're a little less psychotic when they wake up, but that's because they were in a coma. So there's lots of information out there, lots of contention out there about things like medications. The hope being that, eventually we will find medications that are less icky for people. Because antipsychotics tend to be really, really icky, right? Like somebody might develop tardive dyskinesia and then they stop the medication and they stay that way. That sucks. So those are all sorts of things to think about. And yeah, a lot of, what's that?
I was gonna say, what is the cultural perception of the symptomology versus the medical? But I'm sure that like there's a lot of studies on it, but that's
Absolutely. Yeah, absolutely. I mean, that's the whole argument around the medical model is if we treat this as a medical issue versus a sociocultural issue. And again, we have the Fuller Tories of the world who are very much medical model. This is an illness. We need to help these people. And then you have, the Michel Foucaults of the world who are like, fuck you, mom and dad, like means of production. I'm schizophrenic because I'm not gonna, work in your factory or whatever. Both of those things can be accurate. And so the answer is probably less in the middle and maybe a little bit of both.
How do you get them to work together? Or is that possible?
And I quit working for the state because those are hard questions, right? And they're problematic questions because who gets to decide what's a problematic behavior and who doesn't? Does the patient get to decide? And at what point do they get to decide? If I have somebody who is going around murdering people because they're psychotic and they think they're out to get them, that's problematic. And does that mean I get to medicate it out of them, right? According to the state of Oregon, yes. And according to the state of Oregon, they get to be reassessed every 6 months to see if they are still feeling murderous and whether or not we're going to continue to medicate them. In Oregon, we can also, I think I mentioned this a few weeks ago, we can also medicate folks if there's a state Supreme Court case a couple years ago, Sell versus State of Oregon, that allows us to medicate folks for the purpose of being found trial competent. And the state's precedent has been such that we only do that for cases like murder and not something like trespassing or burglary or, nonviolent, less serious offenses. But again, who gets to decide, right? There are other cases I've seen where folks have tried to make the argument that the property crime was serious enough that that person should be medicated for the purpose of trial competency. Things like arson. Arson is one of the few crimes in Oregon that is in the same category as murder. Both of those are felony A's in Oregon. I don't make the rules, but it's different depending on the state, it's different depending on the country, and it's different depending on the culture. So there's a lot of nuance there that all of you sort of next, go out into the world and, oh, the places you'll go sort of stuff. But those are the kinds of questions that you'll be faced with when you graduate and have to make those kinds of decisions. Fortunately, you very rarely have to make those decisions by yourself. There's usually a whole team of people that are helping you make those decisions and ethical committees and all that stuff. So yeah, good luck. I find it flattering that you're asking me, but I don't know. I wish that I had a good answer. There are a lot of things that would be better if we had answers for those things.
But you're saying that you don't have to also helpful, right?
Yeah.
We're still
Nobody really has answers. And if anybody tells you they know, then they're full of shit. 100%. Yeah, we talked about that with personality disorders. So more issues here with treatment. And this is one of the many reasons why folks don't comply with medication. We usually say adherence now instead of compliance because the implication of the word compliance is kind of gross. The side effects suck. They're expensive, and there is, again, that sort of psychological loss. You've taken away from me this thing that had meaning in my life. And that's where things like cognitive behavioral therapy become helpful because a huge piece of CBTP is helping the person find meaning in the delusion, find meaning in the hallucination. What purpose does it serve for them for their life? Okay, you thought the CIA was after you. You had that belief for a really, really long time. Where did that come from? Okay, well, it's because I had this need to feel like I was important, that I knew something that other people didn't, that I had this special knowledge that made me so important that they were after me, right? And people can talk about that with therapy and with ongoing therapy and kind of helping them tease out, what's purpose did these things serve for you? And that's not always the case. Right? Especially if it's something like a somatic hallucination where they believe that there are bugs crawling inside of their body and they start, ripping themselves open, which is a thing that's happened. Maybe that's something that we're going to medicate because that person's harming themselves. And then maybe we're going to help them figure out the meaning. Maybe there isn't a meaning, but there's all different ways that you can treat that isn't just medication right away. And a lot of it is also going to depend on setting and the legality and harm to self and others, all that stuff. Poor relationship with doctors. This one's good. So I've worked with some really amazing, most of the psychiatrists I've worked with are incredible. There's one that I worked with that was a little more paternalistic, and it's because his background was working mostly with folks that are experiencing dementia and geriatric psychiatry, where for protective reasons, that particular subset of the field tends to be more paternalistic because you're working with folks who can't take care of themselves. And so there's this push for things like guardianship and having a power of attorney and sort of these more paternalistic type processes. That particular person did not do as well when they started working with patients that were younger and would say things like, well, that's one of your delusions. And I'm like, this isn't helping. Like, he's getting mad, he's storming out of the room. Maybe let's tone it down a bit and not argue with the guy about whether or not his delusions are real, because that's not how that works, right? Yeah, but you're all therapists, so you're gonna have less of a problem with that, hopefully. Who made that sound? Okay. And there are also bad therapists, right? Lots of people have had bad therapists, lots of people have had bad doctors. I find it interesting that your book only mentions doctors. Whatever. That's fine. I'm going to say it's because it is part of their stream of consciousness that they were getting a little circumstantial because we were talking about medications. And so the sort of next natural thing then to talk about is who does medications, and it's not us, right? Psychosocial treatments. So historically, psychodynamic therapy was not effective, and that's because psychodynamic therapy was not effective for anything in the 19th century, because no therapies were really effective in the 19th century because we weren't doing it right, okay? You know, that's the nature of the beast. Stuff was new, psychology was new, psychiatry was new. You know, Freud was an anatomist to start with, so you know, things get a little sticky there, for lack of a better term, if you're literally dissecting corpses. So now we have lots of other approaches. You know, help people, get people housing, help people feel safe, do therapy, voc rehab, that's fun. Give people a job so then you can say they're functioning and eliminate criteria on B. Okay, cool. Token economies are used a lot. I don't love them because human beings are not rats. Rats aren't even rats, we've learned since Skinner's work. And it's a thing. Lots of places do this. It's effective in changing the behavior. So at the state hospital, for instance, if you got up and went to group, you would get points and you could exchange your points for stuff. It got people to go to group. And if that's the target behavior, cool. Once they're in group, then you can do the real work, right? Whatever. At the prison, they also did this. It was less effective because prison lends itself to people exchanging all sorts of things. You can't buy stamps if you're in prison because stamps are currency. An inmate that is no longer an inmate, and that I'm currently doing some work with, because he was one of my employees while he was an inmate, got in trouble for giving candy to the guys because they assumed that he was giving candy to them in exchange for other things. And he's like, I'm giving them candy because I have money and they don't. And, you know, the guy's nonverbal and he just wants some candy. So token economies can be useful, but they can also be problematic because if you're working in environments that are inherently traumatic, like a prison, or even a group home or a homeless shelter, and you are doing a reward system that is going to lend itself to antisocial type tendencies, right? It makes sense. So it's a thing, be aware of it. Yeah. Community care programs aren't great, but it's what we have because of deinstitutionalization. Community mental health is really where most people get treatment, and they are underfunded, and you will have really high caseloads, and it's really important work. Social and living skills training. So this is a lot of like, okay, well, you have this hallucination, fine. How can I help you make friends anyway? One thing that isn't up here is peer work. There is a movement called the Hearing Voices movements where people do hearing voices groups, and it's really, really popular in Australia, really popular in Canada. Portland has a chapter. Ron Unger leads a lot of those and kind of got that chapter started here. And it's all about, let's get together and talk about our experiences. Let's talk about our delusions. Let's talk about our hallucinations. Let's figure it out. Let's find meaning in getting that from other people that have the same experience instead of this sort of top-down medical model, me telling you that your beliefs are false kind of thing. Really, really, really helpful in helping people function, because maybe it doesn't get rid of the hallucination, but they can have a better life. And if they can find meaning in it, what's the harm? Voc rehab, behavioral family therapy, not my jazz. I'm sure some of you are going toward the LMFT. Good luck. More power to you. I don't know how you do it. I'm not good at it. I work with lots of families and I sit there and I'm like, whoa, you're clearly the problem. I'm not good at nope. So go you. Can't do it. Nope. Yeah, we have.
I would agree. Couples are a lot harder. I'd rather do family.
Yeah, I'm really biased with couples, and I'll tell them that.
Yeah.
Yeah, we do a lot of couples at my practice. I don't work with couples as much when it comes to couples therapy. I work with couples for things like grief and loss. You both lost a child, let's work on that, but we're not doing couples work because I'm not good at that.
Yeah.
And I am very biased when it comes to heteronormative type things. And I know that about myself, so I don't touch it. What we do though is someone will say, hey Liz, I have this couple and I think so-and-so is struggling with this thing and they need trauma work in order for them to move forward in couples therapy, which is a really nice way of saying you're the problem. And then I work with that person. So I have lots of families at my practice where the whole family is at the practice. One person's doing family work and then everyone else is doing individual work with a different therapist, because that's important, right? So yeah, go you. Some people are amazing at it. I'm not one of them.
I don't know if that's what I want to do, but it gave you the most options.
Yeah.
So why not?
Yeah. I have a kid where we were doing sand tray a few weeks ago and he did this whole LARPy scenario, role play with the sand tray toys, and each of them were family members. And I'm I shot over a message to the family therapist. I'm like, you're going to have a really fun week. 'Cause I took a picture of it after and she's like, what happened to dad? And I'm like, well, yeah, have fun. Illness management recovery. There is a free manual on the SAMHSA website that you can download and run illness management and recovery groups. Engages the patient as an active participant in care. That seems really, really, really common sense, but it doesn't happen a lot. There are lots of times where patients don't get to make decisions, especially with things like schizophrenia, because, there's a lot of issues there. This is all about learning things like, what does psychosis look like? What does it mean? What I really like about the illness management recovery workbook is that it's really psychoeducational and it's not just for schizophrenia. So the folks in the group are going to learn about depression. They're going to learn about bipolar. They're going to learn about schizophrenia, all of those things. And so there's not this same, sort of isolative nature of it. It's an interesting group. It's very concrete. It does have, measurable target behaviors and things like that. So, but what's helpful about it is that it's really psychoeducational and it's really teaching people how to look at things like, how does stress impact my hallucinations? How does stress impact whether or not I'm going to have another psychotic episode? All of that stuff. So it's really useful that way. And it's really individualized because different things trigger psychosis for different people. It does address substance use, but it is not a substance use program, but it's thrown in there as hey, here's a thing that could be a trigger. Let's work on that. So we've talked about this a lot. Cultural stuff. Involve family and community if possible. I would also add if safe. Because let's say the person has paranoia about family members, or let's say the trauma has to do with family, but you're not able to really tease that out because the person can't communicate it because they're having so much disorganization and thought disorder and all that stuff. Let's figure that out, right? That's why I'm not good at family therapy, because the first thing I do is look at the parents and I'm like, See, she gets it.
They
Yeah.
bring the kids and stuff there.
Yeah, and I'm like, huh. And that's not always true either, and yeah. Prevention. This is really, 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 really contentious, because how do you prevent something if we don't have any sort of definition of, early identification? That's where that attenuated psychotic syndrome in the new DSM will become handy. And also, I'm not going to stick a kid on antipsychotics because mommy has schizophrenia, because that's bad. What I might do though is, hey, you have a family history. Let's talk about your THC use, right? Let's find an alternative. Or, hey, you have a family history. Let's get you into trauma treatment, because maybe that's contributing to these, experiences of hallucinations you're starting to have. All that kind of stuff. This can also be things like, let's keep you housed, right? Let's keep you safe. Let's make sure you're warm and fed and not living on a tent in the side of Salem where you get run over by a drunk driver or you die, like happened on Friday. Yeah, that was not a good day for Salemites. It was about 2 blocks from my office. And there's a fellow with schizophrenia that is not one of our clients, but hangs out at the office. Because we have free coffee, and we've all decided that we're just not going to tell the guy who owns the practice, because he's not hurting anybody, he just wants coffee. He likes coffee, and he likes to come scribble stuff in the books, and he's leaving notes for the other clients. Like, who cares? They're fine. Yeah, we call him Clifford because he wears a red jacket. He actually calls himself Clifford because he wears a red jacket, but yeah, really sweet guy. But he, came in one day and he just wanted to sit there because that's a thing that happens. So yeah, prevention. It's not so much about preventing schizophrenia, it's more about preventing psychotic episodes. Because schizophrenia probably isn't preventable. We don't have the research, we don't have the knowledge, but you can lessen the prevalence and intensity of these psychotic episodes themselves through things like making sure the person has support, making sure they're safe, making sure there aren't illicit substances involved, making sure that they're housed, all that kind of stuff. Lots of good evidence out there for just having safe and stable housing and how much that reduces the frequency of psychotic episodes. Yeah. Look at that. The numbers say that it works. What I like about this graph, and again, stole this straight out of your book, is that none of these look at just things without medication. They all look at things with medication. And what they don't show you is that on this graph, other research has shown that medication without those things is, in this range down here. So we know that people need medication and other types of help, right? And that's true for all diagnoses. You can't just, shove pills at people and hope it gets better. Medications are necessary, right? Not anti-medication by any means, but as therapists, your job is to do the additional stuff, right? The medication helps create a range within which the therapy can then be more effective.
What's the thing, like I know with medication for Alzheimer's or something. How often does that happen when medication for something?
So Alzheimer's, actually, one of the treatments for Alzheimer's is antipsychotic medications. It can make Parkinson's worse. And that's one of those ethical things, right? And that's true for lots of things. I have a client right now who has heart issues and also has diabetes, and the diabetes stuff makes the heart stuff worse, and the heart stuff makes the diabetes stuff worse. And I'm just like, what do you do? And so really it's up to working with that client and figuring out what they want to do, what they consider to be the more important issue for them. Yeah. And it gets complicated, right? Because people can have multiple things going on with them. One of the biggest problems we have in Oregon and generally in the United States is that we separate things into systems. So you're either in the mental health system, or you're in the IDDD system, or you're in the aging and people with disability system. So you can be IDDD, mentally ill, or old, but you can't be all three, as if people with mental illness don't get old, or people with IDDD don't get old, or can't also have a mental illness, and so on and so forth. And the IDDD system, the person has to be diagnosed before they're 18. Okay, so what happens when I get folks that never got diagnosed because they went to a school with 3 students in some town that basically doesn't exist, and they didn't get an IQ test, and now they're 23 and they're very clearly IDDD based on functioning? What do you do with that? They don't qualify for services. So good luck. Nope. Not if you want to get them into Oregon's IDDD system. So I don't know. I don't write the laws.
Are there facilities for people that are aging that also have severe mental health that focus on elder care?
There are a few. Columbia Care has such a facility down in Eugene area that we sent folks to. The funding stream is where it becomes an issue. So you have to figure out who's going to pay for that. Is it going to be Medicare, Medicaid? Is it going to be the mental health system? Is it going to be that county's choice funds? There's all sorts of stuff there. And that's why being involved in multiple systems is problematic, because they all have different funding streams. Wouldn't that be nice? I lost a client this week because they had the wrong kind of Medicare. And I'm like, are you serious? I've seen this guy 4 times already. We've just started to kind of get into it. And then bam, rejected. And I'm like, well, they can't pay for treatment. I don't know. I haven't decided yet. If you want to do pro bono work as a counselor, that is a thing that is talked about a lot in your little, ethics pamphlets. So good luck. Yeah.
I've received them.
What's that?
I've received them.
Yeah. The whole thing. I've started playing this fun game where I leave things in from the slides that the book gives you, and then I add things, and you can probably tell which things are from your book and which things I've added. So, schizoaffective disorder, basically schizophrenia and bipolar disorder. I will let you read the criteria, but they are pretty much word for word the exact same as both of those. So the person has had major mood episodes, and let's make this more fun. So we mentioned this earlier, the difference between schizoaffective and say bipolar with psychosis is bipolar with psychosis, the psychosis only happens during mood episodes. Schizoaffective, they have had mood episodes. They've had at least 1 mood episode. I think I put the criteria up here. Did I? Yes, I did. So they have had a mood episode during which they had a psychotic episode, but it doesn't have to every time. There's at least 1 though. And they've had a psychotic episode, criterion B, outside of having a mood episode. So it's like all A's are B's, but not all B's are C's. So some A's are C's, SAT type stuff. Be very, very careful with this one on your exam. Use the little handy dandy chart that I stole off the internet that is on Canvas. Once again, with this, we typically see it diagnosed more accurately with folks that have had manic episodes, because depression is a thing that happens when people experience schizophrenia. And a lot of times negative symptoms of schizophrenia look a lot like depression, right? Anhedonia, avolition, amotivation, flat affect, all that stuff. So pay attention to those things. The substance use piece is huge right now in the inpatient population, because methamphetamine use looks a lot like schizoaffective disorder, because you've been awake for days, you're hallucinating, you stopped using, but you're still having symptoms for a few months. Lots to tease out there, and most people aren't going to be inpatient for the 12 to 18 months it takes for their brain to totally clear the damage from the methamphetamine to find out, was it the meth or was it schizophrenia or both? Because lots of people also self-medicate for various reasons, both to treat the illness. Some people will purposely induce things like psychotic symptoms because it adds meaning to their life in some way. Other people self-medicate to stay safe. Here's a real downer for you. almost every cisgender female patient I've ever worked with started doing meth so they could stay awake at night so that they would not get assaulted while homeless. So yeah, that's a thing. What do you do with that? Because now this person is having what appears to be schizoaffective or schizophrenia-like symptoms. What happened first? How did you end up homeless? How did you end up, what experiences did you have before that? So, all those fun, happy, pleasant things that you're all going to encounter in our field. If at any point you want to drop out and become a life coach, no one's going to judge you. I mean, I'm going to judge you, but I won't judge you out loud. It does pay better. Whoa, get back here.
Coaching pays better?
I don't actually know. I'm assuming it does, just because of my own bias, but. Oh, yeah. Yeah.
I think you could be, like an influencer type person, and make money with that,
Yeah.
to really start yourself.
And again, we talked about this before, coaches are useful for certain things. Like if you're starting a practice and you want to pay someone to coach you in starting your practice, that's very, very similar to what we do in the licensure process. Fine. If you have PTSD and you need trauma treatment, please don't go to a life coach. Yeah. And it's also just the socioeconomic things. We are seeing more and more folks go to folks who are coaches because they don't want the stigma of the diagnosis. And that's also a valid issue. And we are seeing a lot of folks become coaches because of the socioeconomics of going to grad school, right? It takes a lot less money and a lot less sort of interruption to your life to do a coaching training program. Let's say you're a low income person or a person who doesn't have access to education. So I'm saying that because I want to acknowledge that I do have understanding of the nuance. And, we make jokes because we need to make jokes to deal with depressing things. By we, I mean me. Psychotic disorders due to other causes, 2 different diagnoses here. The first one is your substance medication-induced psychotic disorder. The criteria look exactly the same as all the other substance medication-induced diagnoses in the DSM with the addition of criteria on A for schizophrenia. They've had a psychotic episode and it's because of a drug or a medication. The drug or medication goes away, the psychosis went away. That's why I brought our friend Tori here. What time is it? It's 8:47. How many more slides do we have? Oh, cool. So, oh, hey, they have ginkgo leaves from the state hospital yard. That's nice. Don't laugh at me. You're being sarcastic.
No,
You're like, oh, that's nice. Liz, why do you have leaves in your sad books?
No, she's serious.
They're pretty. Look at them. These are nice. I picked these 2 because they have like a full C video people. They have a full spectrum of the seasons. Judge me, fuckers. So I just opened to herbal treatments. That's fun. Let's talk about all the different things that can be linked to psychosis. Where's your little chart, Tori? I should have paid attention to the leaves and put them on the right page instead of a random page. What I like about this particular book is that he talks to lots and lots of patients, but also families. So what were early signs? Where did the little chart go that I thought that I saved earlier?